Thank you very much. Good morning, everyone. I did make the cardinal mistake of agreeing to present this title before giving any thought to what I would present, and there's a lot of stuff I could probably ramble on. But as you'll see, I decided to focus on something that's a bit more clinically ready, as you'll see. So we won't discuss all types of AIs and all types of quantification. Before we get started, these are my disclosures, of which only my relationship with Hermes is probably relevant to this specific talk. So we're going to talk about quantification, and let's just, we heard God speak about it in his last slide as well. So what do I mean by quantification? It's an element that adds an objective element, a real measurement of a physiologic parameter is what I mean. And we could talk about other types of quantification, for example, probability of a disease, but that's not really what I'm going to focus on. I'm more concerned with things we can actually measure about the patient from the image. And that enables us to do things like compare to databases, like normal database, to detect disease, to measure changes over time, as we've seen very nicely in the earlier talks. So we can look at things like disease progression and response to therapy. And it can add incremental information to our diagnostics, so adding sensitivity and specificity, predicting who will respond to certain therapies, guiding the therapies, and also to prognosticate. So there's many kind of lung measurements I could think of. I'm sure that this list is probably not complete, but we could look at things like the number and size of ventilation perfusion mismatch defects, some of the stuff that we've seen discussed earlier, lung volumes, measurements out of CT, which we'll talk about a little bit today. We'll talk about relative lung lobe function. And I'd like to point out the contributions to that field, both from Hermes and for Karine from Montreal here for that work. And then there's some early work that I think is very promising, the value of measuring heterogeneity in VQ studies and applications in the context of COPD, pre-symptomatic screening for smokers, and in the context of COVID. And then, of course, we could talk about perfused volumes and indices. And finally, something we've been doing in nuclear medicine for a long time, which I won't cover today, but another measurement is looking at percent lung shunts, is another kind of quantitative measure I could think of. But to do any of these things, what we really need to do is segmentation. So we need to know which part of the image we want to look at and which part of those images are associated with which anatomical structures. And so the way we've been doing that historically is, of course, with planar imaging, as you see an example here. I don't need to go on about this in great details, but you can see the two lungs being segmented and then split into three regions for each lung. And the problem with that is that it just doesn't relate very well to the anatomy. Kind of a similar analogy here. You know, if we were to do that to a map of North America, we would confidently say that Florida is part of Mexico, as an example, and Alaska would maybe be part of Canada. So the way we would get around that is with SPECT imaging. As we know, there's a lot of evidence that's already been demonstrated that with SPECT, we can get around these overlapping structures, so we get a better relationship with the anatomy. We can look at smaller defect size as a result because we don't have to read between all the layers simultaneously. We know that SPECT can be more sensitive for detecting small defects. We can, whereas with planar imaging, we might be able to measure something like areas, but really what we're more interested in is measuring volumes, and SPECT enables us to do that. And as a result, we can also measure quantitatively with quantitative image reconstruction the amount of activity in every particular segment of the lungs. And of course, when we combine all that with CT, we get that additional anatomical information so that we can segment better. We can measure things like lobe volumes once we segment them. So lots of benefit that come with this advanced hybrid imaging techniques. And so as you've seen with Gad's talk as well, we're really promoting the use of SPECT over planar imaging in the context of lung. And so the way we've been doing that in the past was with humans doing the segmentation. The process may vary a little bit from vendor to vendor, but essentially what we're doing is we're starting off with a reconstructed CT image shown on top and a reconstructed SPECT study shown on the bottom. We start off by co-registering them. That's something that's pretty easy to do these days, whether inherently through hybrid imaging or even if you have separate images, we have pretty good registration techniques that work in this context. You'll start by segmenting the right and left lungs and then break those up into their respective lobes on the CT. And once you have those regions of interest on the CT, you apply them to the SPECT to get quantitative measurements on your SPECT. And so here's just a quick series of slides to show the registration, which, as I said, can be done either automatically and or manually. We start off by doing lung segmentations. This can be kind of tricky. This is not a trivial task depending on the types of diseases that you're dealing with. If you have a healthy, normal-looking lung, these techniques work pretty well. So there's quite a strong contrast in the CT between lung tissue and the surrounding tissue. So simple region-growing algorithms using traditional image analysis techniques work very well in these contexts. As you'll see, once we get to other disease types, they tend to fall apart, complicating the task. The next task is doing the lung lobe segmentation. This is where it gets difficult. You'll see in the literature different approaches for how to try to overcome this task using traditional image analysis techniques, taking the CT image and generating images of the vasculature can work well in certain contexts. So that's what's shown on the left. On the right, you see a different approach where we look at the CT itself and we trace the fissures between the lung lobes manually. I'll skip through these series. It's just, I think my updated slides didn't come through, but that's okay. Basically, we do that in a series of fissures to separate all of our lobes. And then finally, we do some quality control to see that, we really have the segments the way they want them. And once we have the segments on the CT, we apply them to the SPECT, as I said, through that registration at the first step. And then we get measures of things like the sum activity as a percentage of the total volume of the lung, as a measure of percent perfusion or percent ventilation from the SPECT. And as you can see in the other columns in this table, once we have those regions of interest, if we want, we can get other metrics that are applicable to each one of those segments. We could get the volumes of the segments, which could be useful, or the percent volumes, and we can get some measurements of heterogeneity. In this case, it's demonstrated as the standard deviation, maybe not the most clinically useful, but just to make a case in point. And then, of course, with automated software, if you want to make your life easier as a clinician, you can also look at automating the production of a robust clinical report that you can submit to the referring physician and hopefully communicate complex information in a more intuitive manner. So one of the early questions in the field was, well, do we need to do hybrid SPECT-CT on all of our patients? The answer from a paper from Knowlman and all from 2018, I think very clearly demonstrates that there is no need to do that. If you have a recent high-resolution CT for the patient, you could use that and save the radiation dose of an additional CT in the clinic. We have early data from Klein in Montreal with Hermes, looking at their software and looking at reproducibility of lobar perfusion and ventilation quantification in SPECT. And basically, I'll cut through these tables to show you that in their work, when they looked at inter-operator variability, they had very, very good agreement between operators of the software. And to just kind of walk you through these figures, basically what they're showing in the vast majority, so the black regions, they had absolute differences in lobar function measurements less than 1%. So very good. And then, even they went up as far as 3% difference, which I think we could all probably agree on is not clinically significant, very few of those. So all to say that if you train your users and you use this manual software, you can get very robust results. This similar work has also been demonstrated in the context of Krypton, which is not relevant to North America. So what does it look like using this software? So the reported work in the literature says that 6.5 minutes plus or minus 1 minute to do segmentation, complete segmentations of lung lobes. I would say that from my experience, there's a few buts to put on that. First of all, there is a learning curve. So using the software may not be trivial. You may need to train your technologists. And I would say that if you come from a hospital like mine, where you have a lot of technologists and they're rotating through, it might be hard to build that expertise within the entire group. So you may want to choose a few technologists that specialize in this and really get good at it. However, as stated, processing time does depend on operator experience, the presence of diseases, which I'll show you examples about that in a moment, the visibility of the fissures, the complexity of the anatomy, and how attentive you are to details will determine how long it really takes. In my hands, my experience has told me that 5 to 20 minutes is a more reasonable estimate, at least with the complex cases that we encounter in our clinics. It can be very tedious. In some cases, it's just impossible. Just the visibility isn't there, or the segmentation of the lungs doesn't work. I'll show a few slides here of just kind of common pitfalls. Here I talk about inaccurate segmentation. I know it may not project that well. It is showing a case where the fissures were not followed exactly. I would argue that in the context of SPECT imaging, where spatial resolution is not all that high, you don't have to be that pedantic. You're talking about spatial resolution of 10 to 15 millimeters. If you're not following the fissure by 1 or 2 voxels, it's really within that point spread function blur that we experience in SPECT. So for the sake of making our clinic flow, don't get too obsessed about that. Another example here is the presence of respiratory motion, which again I think in most cases is a relatively small effect. And then the software is really designed to follow the fissures as we expect in normal anatomy. Once you get abnormal whether anatomy or things that look like anatomy, it becomes a question of really where do I define the fissures. As a physicist, I struggle with this sometimes. And so my word of advice is, if you're putting this in the hand of technology, is to really encourage good communications with the physician so that they can guide whoever is doing the segmentation to follow the fissures as expected by a trained physician. So I spoke about presence of other diseases that may make using software like this difficult. Here you see examples of pneumonia, interstitial lung disease. So in both those cases, you can see that the contrast between the lung regions and the surrounding tissues is not all that good. When you do region growing, you may not get that optimal segmentation of the lung. So that's really a showstopper in some cases. You see a case of emphysema. I would struggle to know what here is a fissure and what here is an artifact. As I mentioned, we use CTs from all sorts of sources. We have old equipment. We want to really minimize our radiation dose to the patient, so rarely do we do hybrid lung scintigraphy. And so we often rely on importing CTs from other modalities, sometimes even from our low-dose PET. And so sometimes you have images that are just pure low axial resolution, and you may or may not see the fissures clearly. I could go on, but in the interest of time, we'll keep moving. So AI, right? Like that's what people wanted to hear about. I'll be very clear. I'm a user of AI. I'm a developer of AI. but I haven't bought into the hype. Nobody here is losing their jobs over AI anytime soon, so please don't fear. The work that I'm presenting here is really that of my PhD student, Ella Hamini. I want to give her credit for the next few slides. So what we've done is we've built a database within our clinic. We basically went back prior to 2023 and collected as many images of patients that were referred to our clinic for SPECT for lung lobe quantification. We excluded 10 of those where we felt that it was just the quality of the images was not conducive to this work. We wound up with 164 images. And then we evaluated the performance of open source, off-the-shelf AI that any of you can download and use using these studies. Just as way of background, this is the distribution of the sex, age of our patients. Almost all of the CTs were acquired with 120 keV, but the currents varied widely as would be expected with patient habitus and technologies. Most of the image reconstructions were done in the axial plane, but some of them were done in the sagittal plane. And then you can see a wide range of cameras that these CTs came from. Some of them from within our hospital, some even from outside of our hospital. And then you can see a wide variety of indications and types of scans. And then, of course, on the bottom, you see a wide range of diseases as well, or presence of diseases. And then also on the right, missing lobes, either through lung collapse or through previous surgery. We categorize each image into 3 classes of what we perceive to be task difficulty. So I could go on about it at length, but basically when we looked at these images, through our experience and through running it through kind of a naive previous AI, we tried to evaluate how hard is it to segment these lungs. And we basically split the images into easy, moderate, and hard categories. And then what we did was we manually segmented the lung lobes in each one of those images. And the way we did that is we started off by running it through Hermes Hybrid 3D. And then we took the results from that and we fine-tuned them. Any holes we filled in. So, if we had like tumors that were maybe excluded, we included that as part of the lungs. If you had big airways, they were included as part of the lungs. And then we fine-tuned all of the borders manually using a program called Slicer 3D. And then we saved those results. Those became our ground truth for evaluating the performance of the AI. So just to give you a feel of what things look like in the various categories, you see here an example of an easy, moderate, and 3 hard cases. And you can see the ground truth segmentations of those cases below. When you do the AI segmentation, the workflow can change a little bit. With developing these machine learning models, rarely do they segment first the lungs and then break up the lungs. They just segment the lobes from the image right away. So it's a bit of a simplified kind of characteristic workflow. But for our perspective as humans, all of this is automated. So you don't really care what happens under the hood, presumably, as long as it works. So the 3 software that we evaluated are Moose, Total Segmentator, and LungMask. All of these softwares were developed with kind of like different intent. Moose was developed in the context of FDG PET CT. So it was trained on CTs from that modality. Total Segmentator was trained on CT. I don't remember the numbers exactly off the top of my head. Moose used something on the order of 100 images for its training. Total Segmentator used thousands of studies for its training. And LungMask was developed specifically for lungs, but it was developed not so much as a tool for lung lobe segmentation as much as like a research project to understand what are the factors that go into making a good AI. And it was trained on something like 100 studies as well, kind of in that ballpark. Regardless, all three of these packages, you give them a CT and it'll give you segmented results as an output, which we then compare to our ground truth to evaluate how well they performed. In all cases, these tools were written in Python, so we could kind of automate the execution of them. So I know it's a busy figure, it's going to get busier, but let me walk you through it. So what you're seeing on the left are the easy classes. In the middle, you're seeing the moderate classes. And on the right, you see the hard cases. And you see the three tools. So in pink, we have Moose. In yellow, we have Total Segmentator. And in green, we have Lung Mask. And the performance metric that we're looking here is the dice coefficient. If you're not familiar with it, that's okay. It basically looks at how well the segmented results we got from the AI overlap with the ground truth segmentations that we have. 1 is a perfect match. 0 means that there's 0 overlap. The take-home message from this slide is that what we scored as easy cases, they segmented quite well. Moderate cases, very good performance. It does seem to fall off a little bit. And the hard cases, it's all over the map. So at least it tells you that we did a good job of scoring what's easy and what's hard for an AI to do. We did look at additional performance metrics. The patterns are the same, so I won't bore you with the details. As a next step, what we did is we took our data and we tried to train our own AI. Now, we didn't have thousands of studies like Total Segmentator. We had to work with the data we had. So we took 164 studies. We split them into a training data set that we used to teach our AI. Those were 111 studies. A validation data set that showed that our AI wasn't overfitting to the data. Those are 20. And then remaining holdout set of 33 images that were used to evaluate the performance of our AI. And we did that in the context of the other 3 open source lung segmentation software. So same figure you saw before, we added to it our model in blue. And really the take home message is that you can see that once we've trained our model using data that represents our institution, we got better performance than any of those other models. You can see that for the easy, the moderate, the impact is not that significant. But if you look at the hard cases, we did much, much better than the other software. I know it's a very busy slide. From a distance, you probably can't see it. These are the same studies that I showed you earlier on with the ground truth, but you can see some of the errors that are made here. You can see examples for Total Segmentator in the hard case on the right as an example where you have a very large lesion and it's being segmented as part of the lung. Our software was able to exclude that tumor and say, well, that's not functional lung tissue. You'll see lung mask, for example, third row from the top. It segments slice by slice. It doesn't do the entire volume at once. And so in the middle there, the first hard category, you can see very clear evidence of that artifact where in some slices, you get like a left lower lobe in the middle of a left upper lobe. So that's an artifact of how that AI was designed. So, it's easy to say, well, you trained it on your data and works well on your data. What happens when you take it and apply it to external data you haven't seen before? We piggybacked on the Lola 11 challenge. This is a database from 2011 that was open to competition. We took all 4 methods and we put them through the competition. You can see that if you look at the rankings, it doesn't look that impressive, like 119th place is not all that remarkable. Bear in mind that this challenge has been open for 13 years now. A lot of participants, some of the participants submitted multiple versions of their software. So there's a lot of people kind of contending for the top. So I wouldn't get too busy with the rankings, even though I'm being transparent here. It's more the score, right? So remember that I said that, with dice coefficient or intersection over the union as shown here, like 1 is perfect. all of these perform actually very well. They're quite close to perfect. Where our method fell a little bit short was in segmenting the entire lung at the edges. There's probably a bit of room for improvement there. But when you look at how well our software scored for lung lobes, we did extremely well, actually one of the top contenders there. So I love AI. This picture was generated by AI. Hopefully you can appreciate looking at the text that AI is not perfect. So the question is, can we use AI lung lobe segmentation? Well, I would say yes, but quality assurance is required, right? So the underlying assumption when I say you can go ahead and use the software is that you still have a physician that's going to look at the results and say, are they good, are they bad? In most cases, they produce very good results. Where it doesn't produce, what are you supposed to do? Well, you still have the manual segmentation as an option, and there are new offerings that hopefully make that better. As I said, in the context of SPET, accurate delineation is not all that essential given the limited spatial resolution. Where can we improve? So this was really one of the take-home messages for us. If we want to do a better job training our AI, really what we need is we need more data. We need more data that is representative of our clinic and not rely on data that was used from PET imaging as an example. There are other AI algorithms that could be investigated that might also improve performance given the same data that we have. So I know I'm a bit over time. I'm nearly there. What does this mean to you? We've developed this as a complete package. Shout out here to Hermes that has helped us out with this. But in our clinic, what we do now is we've built a server now where we can take any of our lung VQ studies with a CT. We can send it to the server by clicking a button in Hermes. We wait about 2 minutes and all the results show back up in Hermes. And then we can open our typical hybrid viewers and view the results. If we like them, those get reported. So that's become kind of like our first line now for reporting these lung quantification studies. And if we don't like the results, well, we fall back on our manual segmentation. We would like to put that in the hands of the community. Coming soon, not quite ready, but stay tuned. Suffice to say that we piggybacked on this infrastructure for other AI applications. We also do now lesion detection in PET-CT, and hopefully that will continue to grow. So I know I'm over time. I think maybe I'll just cut it short. The take-home message is that, we looked at segmenting the lungs, and that's a first step. Now we can really look at applying it at other applications, right? So it doesn't just have to be lung quantification. In the context of surgery planning, we could apply to, for example, COPD, look at measures of heterogeneity, and hopefully that will create new applications that are readily available in the clinic. And I just want to finish this figure from 2015 that I thought was interesting. I come from the world of cardiology, and when writing grants, we always said, well, like cardiovascular disease are the #1 cause of mortality in the Western world. When I saw this figure and I picked out everything that has to do with lungs, lower infections, COPD, and so on, and I tally those together, it actually comes up to more than cardiovascular disease. So for those of us that want to push this forward, please, 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 please use this in your grants, get that funding, let's push this forward. And so with that, I just want to thank you all for listening, and questions will come later.